Hey, everybody, it is Kevin Henry, editor-in-chief for drbicuspid.com. Thank you so much for joining us for another episode of the podcast. I am thrilled today to have on a dear friend of mine and a contributor to Dr. Bicuspid, and that is the amazing Estela Vargas. Estela, how are you, my friend?
Doing fantastic. Still recovering from the AADOM trip last week. It was so much fun. It was nonstop.
And I was so glad I got to see you. Estela and I were both in Round Rock, Texas recently for the American Association Dental Office Management meeting. I thought it was a fantastic meeting. And I know you had some great crowds while you were there. And congratulations on that.
Thank you. Thank you. I wasn't expecting it, but yeah, the rooms were sold out. Sold out. It was crowded in there and it was fun. Yeah.
Well, I want to talk to you about the AADOM conference and kind of some things that were asked of you. But before we dive into that, tell people just a little bit about you before we dive in.
So I'm Estela Vargas. I am a dental hygienist. I am also the founder and CEO of Remote Sourcing, a dental billing company and outsourcing company as well. We help dentists all across the country with their billing needs.
And Estela is, like I said, a regular contributor to Dr. Bicuspid. We're going to put a link to her articles in the show notes. Or if you're reading this on Dr. Bicuspid, hey, just click on her name. You'll be able to find it very easily. So, Estela, as I said, you had great crowds. I know a lot of people were picking your brain on things. What were some of the buzzworthy topics that you heard about and were asked about in Texas?
Absolutely. So one thing I appreciated about the crowd is that they were very engaging and they weren't afraid to tell me what was going on in their region of the country and the struggles that they were dealing with. And the first course dealt primarily with billing for periodontics and crowns. And it didn't just focus on SRP. The whole course wasn't on SRP. It actually was just a small section of it, but we touched on many other codes that people get struggle all across the country. They struggle to get paid and reimbursed for. And the biggest impact in the perio section was the audience actually understanding the difference between a gingivectomy and anatomical crown exposure and crown lengthening. Those are three separate codes that get intermixed often, and doctors aren't sure how to code for it exactly because procedurally, I mean, they're doing the same thing day in and day out when they're prepping crowns, when they're treating gummy smiles and things like that. So, gingivectomy, we all know what it is. We're just removing excessive gingival tissue. Anatomical crown exposure is whenever you have a patient that has a gummy smile and you need to flap the tissues out and then remove bone structure. So, we're not just going to be removing gums, the gingiva. We're also removing bone structure to give that patient a beautiful smile after. I even showed a case from my friend Dr. Daniel Melker, fabulous periodontist, and it had beautiful results. And then there was confusion with clinical crown lengthening because this one we're also flapping, we're also exposing the bone, we are adjusting the bone. But the difference is the crown lengthening is the purpose of it is to retain a crown, and the other one is to modify the smile for the patient. And with billing, yeah, go ahead.
No. I think you're getting ready to answer my question. So go ahead, please.
With billing, often doctors are prepping a crown and they're using a laser and they're removing excessive gingival tissue around the crown so they can get a nice impression, they can get good margins. And they're billing that as crown lengthenings, which is causing tons and tons of audits and it's getting doctors in trouble. So it was very important for the crowd to understand the difference between the two.
And so how do you take that back from a conference and actually put it into play in the practice? Is it just as simple as really understanding the codes and then implementing that understanding in the practice?
It depends. So with crown lengthening, with imaging, for example, if we want to get insurance coverage, since, the topic is always, how do I get paid for this? How do I explain the procedure to the patient? If we want to get paid from insurance, we need to document everything that we're doing with that clinical crown lengthening. So with that one, we need pre-op x-rays and we need post-op x-rays, or at least images that show that the bone was remodeled. No carrier is going to pay for this procedure unless they have evidence that there was bone remodeling. And if we didn't touch the bone, then it wasn't crown lengthening, it was a gingivectomy.
And is that something that has been pretty standard through the years, or is that something that's evolved as well?
It's been standard. It has been standard, but like I mentioned, a lot of doctors are billing for it incorrectly and they're getting in trouble for it. So
That's a great tip right there. And obviously, again, was your audience mostly office managers, or did you have a mix of dentists in there as well?
we had a good mix of dentists and they were very vocal, which I appreciated because it's important for managers to also hear the perspective of dentists when it comes to billing.
Absolutely. And that is one thing I've enjoyed about that evolution of that conference is it used to be just for the front office, but now I see a lot of dentists coming to it as well. And there's a lot of good interaction that comes from both those parties being there.
Exactly.
Yeah.
Exactly. From the perio codes, we moved on to touching on bone graft codes. And when I put up a picture, I had a picture of the four different types of bone grafts, where we're doing perio for ridge preservation, endo, and then implant bone grafting codes. And I could see the light bulbs popping up when they realized that we're so used to using 7953, which is ridge preservation, that we get stuck, and they're seeing so many denials because they're coding incorrectly. And those are automatic denials. And they're trying to appeal it, and the appeals aren't being won. And it was because they weren't using the right code. So one of the managers asked, but how am I supposed to code then if we're doing an extraction and an implant placement the same day? So there's two different ways that you could code for this. If you're doing an extraction by itself and you're going to stitch everything up and close it and then see the patient later to drop in an implant, you'd use 7953 for ridge preservation. Or let's say you did multiple extractions and you want to prepare that ridge for a bridge, you would use 7953. That can only be used on an edentulous site, meaning there can be no tooth there. Then if we're placing an implant on the same day, we would be using 6104, which is bone graft at the time of implant placement. To answer that manager's question, if you're extracting and you're putting an implant same day, it's 6104. You start coding that way, you're going to stop seeing denials.
That's a fantastic tip right there. And I know a lot of folks who were not at the AADOM meeting are writing that one down because I'm sure that that's a big problem all across the country.
Absolutely. Yeah.
So tell me about your other course that you had as well.
I had another course, and it was all about how to prevent denial. So I moved on to this code. I mean, to this this course. And on Thursday, I had an interesting question that I ended up implementing some slides for it for the following course because it was necessary and needed. But before I jump in there, I wanted to touch base on the crown sections because we talked
Please.
all about the perio in the first one. Yeah. The crown section, I was expecting to get more questions about core buildups and how to get paid for onlays and inlays and things like that. But when I saw the biggest impact in the room and everybody's eyes lit up was when I started talking about ICD-10 codes. And the audience had no idea that there are ICD-10 codes that described cracked tooth syndrome, pulpitis, whether it's reversible or irreversible, open margins, over-contoured crowns that lead to biologic width invasion, and many more types of ICD-10 codes. Like I pulled up the coding books because they're asking me, how do you even figure out what code to use? And the coding books from the ADA all have them at the end of the book. So this is something that's always with me. Those books are with me all the time because there's over 900 codes and thousands of ICD-10 codes, and it's impossible for me to memorize them all.
I feel like we've talked about ICD-10 codes for a while, and yet it's something that still a lot of people don't either understand or don't feel like that they can actually use in their practice. Am I incorrect on that?
Yes, yes. And, there's a lot of buzz going around that it's going to become a requirement, and it already has become a requirement for Medicaid. So Medicare and Medicaid services have started to implement that, and it is a requirement for offices that are billing Medicaid. I don't know if it's nationwide yet, but it is a federal requirement now. For PPO practices and private practices, it is not a requirement yet, but it is important to start getting used to the idea because it's coming. I'm not happy about it. It's more work for me, but it is coming.
And I'm glad you said that because is this something that I know we're still at the end of 2025, but is that something people need to be focused on in their practice maybe for 2026?
I think so, and at least start to get acquainted with it and start using it. For example, let's say you are a biller or you have a biller in the practice or you're outsourcing it. If I have an ICD-10 code that is describing the doctor's diagnosis for that procedure that they did, a carrier, an insurance company cannot argue with the doctor's diagnosis. So it's important to have that in the clinical notes because it gives me the ammunition I need to appeal that and get paid without having to chase down the doctor for an additional narrative.
I mean, it's fascinating to me to see how things are changing and how yet it feels like that we're in some ways still stuck in the past whenever it comes to what we feel like we've always done and we just keep doing it. And how do we get people to pull into this year or even next year to be looking ahead to what's best for their business overall?
Well, the fourth quarter, right now, there might be a little bit of a lull in the schedule. Kids are get back to school. Families are trying to figure out what they're going to do with their schedules. And we start seeing a lot of appointments being dropped or rescheduled or people putting off treatment. Hint, there's an article coming out about that.
Ooh.
And now is the perfect time to when you have a little bit of extra admin time instead of, focusing on filling the books and things like that. Focus on what you can improve and the processes that you can improve so that when the schedule picks up again, you can get off to the races and start getting paid.
Fantastic advice. And obviously, I know I touched on your second class, and I don't want to hold you back from some of the things that stood out from that.
So with the second class, it was strictly all about how to prevent denials and reduce the amount of rejections and appeals that we're having to deal with because it's becoming more and more common. That is one of the things that I hear complaints about constantly. And you know, I touched on a few things that hit a nerve for some people. So for example, in one of my first slides, I had a screenshot of clinical note. And it was a good clinical note. It was a medium length note and it had a full description. I'm going to read it to you a little bit. So patient presentment for treatment, 18 PFM crown, indirect buildup, and gingivectomy. And then the doctor went on to describe the fillings that she completed. She described the anesthesia she used, the materials she used, all in detail, everything that she used. And I put that up and I asked the audience, is this sufficient to get the crown paid? What do you think the audience's response was? Yeah. Across the board, everyone said, yeah, but it's not. It is
Okay.
not. It was an excellent clinical note. It had everything that you'd theoretically need to get paid, but it was missing the why. Why did we need this crown? What was the diagnosis? If a carrier sees that clinical note, they see the x rays, they see the intraoral images, they see the post op PA, whatever they're seeing, they're going to still need a why this was done.
So, and we hear so much about AI on this side of the equation. Do we still need the why as much, even with AI helping us on the dentist side as well as on the insurance side as well?
Yes, and that's also a common question I get with perio, like SRP claims. I'm a hygienist as well. We used to be able, I don't know, 10 years ago, we used to be able to just send the perio chart and X-rays, and that was sufficient to get the claim paid because it was a human reading your documentation and they could see it with their own eyes what's going on. But now I'm seeing a trend where claims are being auto adjudicated. So they're being automatically processed. So there's an AI reading the clinical note, reading the perio chart, reading the x rays, and seeing if everything matches. If there's information in the clinical note does not match the codes that are being billed with the documentation submitted, you might receive an automatic denial. So,
Okay.
and it's happening with crowns, with perio, with any kind of procedures that require attachments.
Great tip. Hey, anything else that you want to highlight? I want to make sure I give you a chance here if there's any other things from that second course or even anything else.
Yes. So in the second course, I had an office manager ask this question, and I'm going to read it out loud. Estela, you mentioned that some of these restrictive processing policies leave patients with unexpected bills, and many offices write off tons of balances because of waiting periods. So she was stuck on that waiting period one. And that's something that you can prevent if we're verifying benefits thoroughly before that patient comes through. She kept saying, I was taught that doing blanket write offs like that is fraud. If we're in network and our contract strictly expects us to collect copays, how can it be right to do these write-offs? And this is a question I get asked often because some offices aren't sure if they're, crossing on the gray area or they're full on crosses into the fraud territory. But she said it herself. These are unexpected bills. The patient paid their estimated copay, and you told them that the insurance would pay their part. Now, to clarify, that's what the patient heard. We always tell them that it's an estimate, but the patient heard insurance is going to cover that part. I'm not going to pay for that. So the patient's now stuck with a hefty bill and they're not financially prepared to pay it. The compliance part of this whole question is if you bill them and then the patient can't pay it and it is documented that they're going through some sort of financial crisis or they just cannot afford to pay this bill, the doctor doesn't send them to collections. It's not part of their protocol to do collections. They now have what is called an uncollectible balance. In these instances, it is okay to write that balance off. We did try to collect it, the patient could not pay for it. So it is okay.
Okay. Great tip right there. Great tip.
Yeah.
And
Yeah.
I feel like people, you mentioned people kind of get hung up on things. And again, is it just one of those things that this is the way we've always done it? And sometimes people don't evolve whenever the codes evolve or whenever things may evolve in the industry as well.
Yes, it's hard to stay up to date. Even for next year, I'm sure with Teresa, you've talked about this before too. There's going to be 60 code changes. That's a lot to keep up with. And if you're not reading my articles or going to these courses or, like it's staying up to date with it, we stay behind and then we bill incorrectly. And then we start seeing the money, the cash flow starts getting affected. So it's important to stay up to date.
Well, and that's why I'm so thrilled that Estella works with us at drbicuspid.com, as well as she's a great resource for all of you out there who may have any questions. So, Estella, let me make sure to give you a plug and to let people know how to get a hold of you or to learn more.
Absolutely. I take questions all the time. On my website, I have an FAQ of the most common questions I get emailed regularly. So please don't hesitate to reach out to me and send me your questions. I'll make sure to respond and I'll even add them to the FAQ because if you have that question, I guarantee you hundreds of others have it too. So you can reach me at info@remotesourcing.me. Email any questions there and I'll be happy to get back to you.
We're going to have that website and the email in the show notes. Very easy for you to find. And again, if you're reading this on drbicuspid.com, just check out that hot link that is in the article and you'll be able to find Estela's information very easily. My friend, it was great to hang out with you in Texas, and I
Pleasure.
appreciate you bringing some knowledge back with you.
Thank you so much. It was a pleasure. This was fun too.
Yeah, yeah. I always enjoy chatting with you, and I always enjoy whenever people listen in on our conversations. So thank you for being a part of this episode of the drbicuspid.com podcast. Absolutely. Again, in the article or in the show notes, we're going to have a link to all of Stella's articles, some great information to help you with your insurance and to make sure that you're doing it the correct way in your practice. Until next time, it's Kevin Henry, editor in chief, signing off. And as always, wish you nothing but success ahead.